morning. Dr. Ashman, if you want to go ahead and get started.
I'm going to unmute myself. Jackie, is the sound okay? Sound is okay? Thumbs up?
Yeah, sounds good.
We can hear you, Dr. Oshman, yep.
You may or may not be able to hear my Chihuahua as well. Benefits of working from home. Someone will let me know if he is too loud. So welcome, I'm Lauren Oshman. I'm one of the co-program directors. Dr. Richardson will be holding our other PO work group, which will be on the 24th. We'll show you our agenda on the next slide. So our hopes for today, we're going to do some introductions, go through our dashboards and get some feedback from you about how they've been working so far, and suggestions and information about our next iteration. We'll talk about the experience of our accelerated sites, some feedback about our trainings and our plans to test our interventions, and then we'll walk you through our upcoming events and deliverables. Jackie, any specific introductions you wanted to make before we get started?
No, I was just going to ask that if anyone does have questions or comments or gives input on anything, if you could just introduce yourself and say what PO you're from, that would be great as we all kind of start to get to know each other a bit more through these meetings.
And then do you want to introduce any of our other stakeholders who are here?
We also have Jake on the call. He is our quality improvement specialist. I think many of you have heard from him before or seen him on trainings as well, and he'll be working closely with all of you as we roll out this program as well. No one else from MCT2D is on, but yep, if everyone else can just let us know. Oh, we also have MDC. I'm sorry, I completely forgot. We have some representatives from the Michigan Data Collaborative here as well. I see Susan's on the call as well as Lori, and they're here for any feedback, and Marty as well too, about the dashboards and your experience of them so far too, and we'll be able to answer any kind of specific questions that you have about them as well.
Awesome, thank you. So I'm going to go through the next few slides, if you'll proceed to the next one, about the dashboards, and then turn it over to our representatives from MDC, Jackie and Jake, to answer any of your questions. I think just as a lead-in, it's really exciting to be with you today. We've been doing a lot of work, creating a lot of education for our clinical champions and behind-the-scenes work to get the collaborative going. It always feels a little bit like you're building the plane while you're flying it, but I honestly think our plane is flying pretty well considering everything, and we really appreciate your partnership with making this work as well as possible. So let's talk a little bit about the dashboards. We are very, very pleased that our dashboards were able to launch on the 1st of November. You should have in other words, all of your onboarded users should have received an announcement from MDC about the dashboards, and they should be able to access them at this time. So anyone who is having trouble with accessing the dashboards, would you please let us know, or have your users let you know, so they can follow up with us. We did follow up with the POs who need to confirm their acknowledgers at the end of last week. So just let us know, anyone else at the PO and practices that should have dashboard access, and we can make that accessible to them. Next slide. So in the chat, if you could let us know, or please unmute yourself if you'd like to, if you do not have dashboard access, what challenges can we help you with in getting access? And if you do have access, what barriers have you run into with accessing the data, the display, the information we're able to provide? Some of this we may be able to iterate now. Some of it will work with MDC for our next iteration of the dashboards. Any comments, suggestions, other things you'd like to offer about this?
Yeah, we would really love to hear from you all, whether you've accessed it or if not, why not, and what you need from us. So any questions you have right now about the dashboards, the data, let's discuss.
And Dr. Oshman, I did put in the chat, if anyone needs access and does not have access, to reach out to MDC account and we can get you set up.
And while you're thinking about your questions, I'm going to go to the next slide and just raise our questions that we have for you about the dashboard experience. We are curious to see, for those of you who've looked at the dashboards so far, what do you think is most useful? What is your highest priority? The information that would add the most value as we put our energy into upgrades? And is there anything regarding to navigation that we could improve for your usability and experience? If anyone wants to unmute or share with us your experience so far. Some folks that still need access.
And if there's anything you need or are unsure of as you're trying to get access to them, please feel free to reach out to me. I'll make sure that we get all your information in the right place, or let you know what we're still missing or need from you to get you that full access. So.
If there's anyone who already has access who wants to share your experience so far, we'd really be interested in hearing it, not to put you on the spot in front of this large group, but please feel free to share.
Can you hear me?
Yep.
Yeah, good morning. This is Erica from Olympia Medical. I just had a quick question. I was playing around with the dashboard. The MDC data dashboard at the very bottom of that table, is that where you envision the future data to be housed? When I click on it, it says I don't have access to it. I just wanted to make sure that that's correct.
Laura or Marty, can you try to answer that question?
Or can you repeat where were you clicking on to try and access?
Yeah, so when I open up the dashboard, it shows me the table with the status, and at the bottom, the very last row, it says MDC data dashboard.
So you're when you see the table, I'm just not sure what reference. So you'll log in and you'll put in your user ID and password, and then are you brought to a page that you can select which dashboard you want to see?
Yeah, I guess, and maybe this is something for me. I need to get access. It's saying I do not have access, so maybe I can follow up with you.
Sure. Yeah. And I'll put my email in the chat, so you can just send me a screenshot, maybe directly of what you're seeing, and we can follow up.
Okay, great. Thank you. It looks like it takes me to the Tableau, the MDC dashboard, but then it tells me I don't have access. So yeah, I'll follow up. Thank you.
Okay.
I think that's a good segue to the next slide. We have set up some trainings to try to help make sure that you get the most out of the dashboard experience. And I think it'll be helpful to look through Tableau and see what the most useful ways to slice and dice that data are. So please feel free to attend the training sessions, make these available to those who you think will benefit the most in your POs. Jackie, any other suggestions for who would be the best trainees to attend these sessions?
I think really what will be most essential to have understand how to use these dashboards really well would be the PO admin lead, the PO clinical champion, and any practice clinical champions as well. That is who should have the best understanding of these dashboards, but really it would probably benefit any user with access to it to attend these and just learn a little bit more. There's a couple questions in the chat for MDC. How do they sign up for these trainings?
They can just attend the training through the link that was sent, so they don't need to sign up in advance.
Okay.
And I can put the link in the chat as well. I think it was sent out in some of the initial emails, but I'll go ahead and add it to the chat. We will record a session and post it on our website. So if you aren't available for some of these sessions, and then typically what we've done in the past is, depending on the participation, we may extend or add additional sessions. And Jackie, we can let you know to communicate that out. So we just kind of see what the participation is before we move forward with that.
Sounds good. So can you definitely put that link in the chat then? Because since that email you sent out, I believe was only to users that had already been onboarded. I think there's probably many on this call who don't have that link and may like to attend. Is it just one link and they can attend any date or time?
Yes, yep, it's the same link and
Okay.
same password throughout all sessions.
I think that would be helpful considering there's only 3 more trainings and I'm not sure everyone will have access, but may want to attend and be able to ask questions. So if you could put that in the chat, that would be great.
Lori,
Yep,
just to
I will add it now.
Lori, just to clarify, they can attend even if they don't have access, correct? Just preemptively.
Correct. Yeah, yep. So they can
Okay.
attend if they don't have access, and then just to see if there's an interest in getting access. Yep.
In
And
addition
the
to putting
dashboards we show in training, it's fake data, so it's not true patient data. So anyone can attend the training.
So in addition to putting that in the chat, Jackie, can we send that out to everybody as well?
Yep.
Again,
Absolutely.
and we'll
Okay.
update again as we have more sessions available.
Sounds good. And we'll likely circle back and revisit your experience with the initial version of the dashboards once more people have been onboarded and have had a chance to access it. We plan the agenda for this meeting prior to them launching, and we're hoping more people will be able to access it and have some experience with it first, but we'll revisit this in the future so that we can discuss this and learn about your experiences from it. Okay, Dr. Ashman, next to our next version of the dashboard.
Absolutely. So what you will find if you have not already logged on is that the dashboard will show you patient name, type 2 diabetes, their age, A1C, BMI, and weight, and is filterable by age, weight change, BMI, insulin, short-acting, long-acting, GLP, and SGLT2 status. Our thought being that those would be the most important things right away to start filtering your data and identifying patients for outreach or where your practices stand in general. With the next iteration, we're planning to add other diabetes medications, sulfonylureas, other medication classes that might help the clinicians decide what changes they want to make, as well as blood pressure data, which I think will be very important to identify those patients at higher risk, and the other kind of actionable risk-reducing diabetes interventions that are typically in our pay-for-performance or value-based care metrics, including ACE inhibitors, ARBs, and statins, aspirin being at this point in flux for patients with diabetes and without. So just last thing to mention in the chat, or again, you can feel free to get back to us by email or at one of the training sessions. What other suggestions do you have? Anything else that you think might be useful to prioritize for the next iteration?
I was going to say,
Hello.
if it's go ahead.
Go ahead.
I was just going to say, if it's too early to, I know that the dashboards were released on the 1st, so we could always come back at a future session and reach out and solicit feedback at a later time as well.
This is Bobby. I'm a pharmacist with the Lakeland Care PO for Spectrum Health Lakeland. And I'm not sure if this would be possible or not, but just something that kind of comes to mind looking at filtering data and dashboards and kind of getting leads would be diagnosis status for like chronic kidney disease or maybe certain ASCVD related diseases, because I just feel like those are really easy wins to try to get somebody on a GLP-1 or an SGLT2 as like, clearly a better choice than the other alternatives. And it could be an easy sell for them and the primary care providers. I'm just not sure if that's a feasible thing to include, but something to think about maybe.
I can take this, Lori, if you'd like. So that's a great point. Thank you for bringing that up. And that is something that we are actively working on. That is something that we're hoping to have actually ready to go in release 2. And if not, potentially in the release after that. This isn't an exhaustive list. This is the things, we only listed the items that we were very confident that we could definitely have available. We are working to have an entirely additional tab on the dashboard that will contain a plethora of CKD related diagnoses, medications, lab values that can be used in conjunction with the more diabetes focused tab, if you will. And that'll include diagnosis of CKD stages, microalbuminuria, urine creatinine ratios, things like that, to really help with that portion of their care. Lori, anything you wanted to add to that?
No, I think you covered it.
Great suggestions. Anything else? I'm going to move on to the next topic and tell you a little bit about our accelerated sites. So we're working with 4 accelerated site POs. They are going to be the first to test and implement some of our collaborative-wide efforts, looking at improving prescribing of SGLT2 and GLP medications, use of CGM to drive activity changes, and lower low carbohydrate diets. So thanks to Medical Network 1, Wexford, Oakland Physician Network Services, and Henry Ford for being our accelerated sites. It's been a great start. I'm going to go to the next slide and tell you a little bit about what we've done so far. We did have our accelerated sites already attend our trainings, which are ongoing and will be going on, I think, through December. And we've asked them a little bit about what they wanted from the training from us with regard to rating the quality of the training. Did it meet your expectations? Mix of presentations and activities, suitable, what was most helpful, able to get their questions answered, quality of the instructor, suggestions for us, what they learned that was new, what we were missing, and any suggestions. So I want to go through some of the changes that we've made based on that input. Next slide, please. So we really learned a lot from the initial trainings, I think specifically with the quality improvement gap between providing information to POs and clinicians and then implementing it into practice every day. And so one of the biggest asks was resources to give to patients for low carbohydrate diets or for clinicians to use as they're talking about low carbohydrate diets. And that includes tracking logs for patients and different apps that we find most helpful for tracking dietary interventions. How to introduce a lower carbohydrate diet, how to talk about this with a patient, how to bring up the topic, how to make a successful referral to a dietitian or someone else in the practice to provide the education. What's the appropriate follow-up? So once you start that dietary change, when are you going to see the patient next to see what's been successful for them and what challenges they've had? For medications and in some part for CGMs as well, the biggest barriers identified were for coverage, cost, and complications of formulary and what's most appropriate choice for patients. So regarding that, we're in the midst of developing several tools that we'll make available to you. And one of the requests really was that these tools should both be for clinicians, but also directed at patients. This piece of patient motivation, patient engagement, patient empowerment so that they can bring information to their clinicians about what their insurance provides. So one of those handouts will be questions for patients to ask their insurance, specific resources for Medicare for insulin and medication coverage, and then for commercial insurance, finding the appropriate covered or formulary-based SGLT or GLP. Handouts for dosing and dose escalation, and handouts for patients on each medication class with all of that anticipatory guidance, what to look out for so that clinicians doing this maybe for the first time or who haven't used these medications as much can feel like they're providing all of the necessary education. And then for CGM, similarly, providing some information about getting them covered and some of the nuances with Medicare and coverage through pharmacies versus durable medical equipment providers. We've iterated and added additional cases just to make sure that we're tying it all together and in really highlighting these barriers. And so I will tell you a little bit about what the accelerated sites are doing and then just ask if you have any questions or comments in the chat as to your feedback or what you think about any additional tools for us to develop or ways to make this training more effective. Next slide. So each accelerated site worked with us to choose 8 different clinicians who agreed to pilot MCT2D with 10 patients. So for each of those patients, they will select one of our 3 interventions, if not more than one, make that recommendation to the patient, and then provide us with feedback about how it went so we can iterate and provide more tools for future clinicians to use. For the patients who received the intervention, we're going to be collecting, just for this narrow group of patients, some patient-reported outcomes on how their experience was, what their success was like with the intervention, whether they felt like the clinician was patient-centered in the discussion, et cetera. And so those patient-reported outcomes will, I think, really help us tailor these interventions for the rest of our sites for the future. So any questions, comments, or other suggestions about our accelerated site experience or trainings? If any of your champions have been through them, if you've been through them and you have any suggestions, please type them in the chat. If you want to unmute yourself, please feel free to. Just a question about the accelerated sites, Jackie. Are they in academic, independent, or outpatient practice settings? What can you tell us about the practice size and affiliation?
So it's kind of a mix of all. So Henry Ford has some kind of, more academic settings, I would say, for some of theirs, I believe. And then the majority of the rest will be kind of independent outpatient settings. We did try to, in our accelerated sites that we chose, select those that would be representative of the collaborative as a whole, both kind of geographically, practice setting, et cetera. So we tried to get as kind of broad of reach there so that we could better translate their experiences to the rest of the collaborative. Mm-hmm.
Thank you. If you have other comments, suggestions, compliments, complaints, please feel free to let us know. I'm going to move on to the next slide. So we're going to give you a brief overview of our year at a glance, what's coming up. On the 15th of November, the specialist practice affiliations are due. So we're going to ask you to submit these via the link that was shared to you. If you do not have the link, please let us know in chat and we will resend it out. If you're not recruiting specialist practices, just let us know so we can confirm that we have closed the loop, have an answer from you. Steering committee nominations, Jackie, anything else to add about the details for that?
Nope. We sent out in the email the different kinds of specialists and the seats that we'll have for them and who we'd like to include. If you do, once you have your specialist recruited, have some that would want to participate, that would be great. I think we still are kind of short in those kind of seats that we're looking to fill. But yeah, I'll send out another reminder as well, like a week before that, just letting everyone know it's kind of a last call, last opportunity to add people. And similar to what I just said about the accelerated sites, what we'll try to do with the steering committee is make sure that it is as representative as possible of the collaborative and try to include as many people from as many different organizations and everything as possible.
Great. Moving along to patient advisory board, our meeting is set to be held on the 1st of December. Really, really excited about this opportunity to make sure that our interventions, activities, handouts, everything is focused on what patients need. So the goal of that first meeting will be to orient those advisors to MCT2D, ensuring they understand their role. Most of you have worked with patient advisors before, and talk about really that key barrier that we've identified of patient empowerment and get some suggestions about what to do next. Any other things to add about patient advisory board, Jackie?
Nope, I think that's a great overview. If you have any questions about anything in particular, happy to answer them, but we're definitely excited to have our first meeting with the patients and begin to kind of include them in the operations of the collaborative.
So then the last thing on this slide is our collaborative-wide meeting that we hope and anticipate will be an in-person meeting at the Inn in St. John's. It will be really wonderful to be able to gather together in person, as most of the other CQI programs have done over the years. So just look out for that registration. Jackie, anything else to add about that?
Nope, but we will keep you informed about the status of that meeting being in person. I know these types of things are still a bit in flux, so we will communicate anything that we know as soon as we have more information on that, but this is still the tentative plan.
Next slide, please. Most of our other CQI collaborative colleagues have worked in regional collaboratives. And so the idea being we're such a large group, it might be beneficial both for shared concerns and also just for ease of communication to break up into regions. We're outlining a draft that we'll share with you soon for your review. We'd like your help requesting whether you think your assignment to a different regional part of the collaborative is most helpful. And this will be the basis for breakouts for spring and fall meetings so that hopefully we can be geographically located in such a way that your clinical champions can attend an in-person meeting. I think it's going to make sense for us to have some online Zoom-based and some in-person trainings, but we're hoping to make that possible with these regional collaboratives. Dexcom, we're very excited that they have offered to do a specific training for MCT2D sites, and they're going to be doing that on Tuesdays in November from 12:15 to 1 Eastern time. So we will share or have shared those links with you and place them on our website as well. And then our VBR dashboards with the updated information about who's completing the training will be shared with you later this afternoon. Anything else to add on those 3 items, Jackie or Jake?
Nope, I think that is it. If anyone has questions about any of them, always feel free to reach out to me and I'll make sure to get you the answers you need.
So if no other questions about the upcoming events year at a glance, we're just going to move on to ask for your feedback about a couple of discussion items. One of those discussion items is we have been approached by, as you can imagine, pharmaceutical companies who'd like to collaborate or work with us. It's very important to us that MCT2D is an independent organization based on evidence-based data, working with the needs of provider organizations, practices, and patients. I have some thoughts and concerns about how working with pharmaceutical companies might be beneficial and also might create bias or not be beneficial. This ties into a second question or concern, which is that so many of the barriers that your trainees have been sharing with us in the trainings have been based on cost of our interventions, whether that's medications, affording healthy food and a low carbohydrate diet, or using CGM, that any opportunity that we have to advocate with stakeholders and cost is really important. So if you have any suggestions in the chat about whether you'd like to have us facilitate or work with pharmaceutical companies, like to have us avoid that, or any other suggestions for how we can work on cost of interventions, please let us know. This is my last slide, so discussion is open from here.
I think it would be helpful if the pharmaceutical companies do have support for patients who maybe can't afford it. If they're, sometimes that process is really challenging. And so if there's a link or paperwork our patients could fill out for that access, that would be helpful to have.
Hi, this is Bobby again, pharmacist. Just following up on that comment, I just wanted to put a little information out there. As far as the pharmaceutical reps and what they've provided kind of for me and for my offices and what concerns I have, I feel like a lot of the educational stuff that they can provide is something that we could provide, or that could be provided from the collaborative, using references, kind of like the last commenter just messaged, links. Like, for example, I have a page of all of the links that I use for all of the different manufacturers, so I don't, have to call the guy at Lilly and say, hey, I need help with this. It's something that can be kind of independent from the representatives, I feel. And then same thing with like the savings, there's the savings apps, and then there's also the savings cards. Basically all you're doing is either going to the app for people who have certain financial situations, or you're going to the website for the cards for the other folks. And that's basically all there is to it for the reps, besides clinical information, which we're getting from our trainings, and samples, which are just kind of good for bridging gaps. And I don't think we really want to be doing that for a long term anyway. So just a couple thoughts on that.
This is Beth Gentner. I agree with that as well. And I think the other thing that I would have concern about is that I think the idea of this collaborative is long-term solutions for these problems that we see in the practices. at actually getting our patients this evidence-based treatment. So I think leaving those conversations to the collaborative and, you know, the payers on the cost of these treatments is where that, I think that's rightfully suited for that area, as opposed to having the pharmaceutical providers come in and directly continue to work with the practices. I think that would slow the progress of what this collaborative is looking to do, I think.
See some comments in the chat reiterating what I've heard so far, that there might be some benefits for linkages with pharmaceutical representatives just for the materials they can provide, but that we might be able to provide some of those ourselves that are more class-based, agnostic to provider, not labeled or branded, and have similar information. And so we may reach out to some of you or ask that if you have really excellent materials already, to send them in to us. I agree that that might be information we can provide. I'm assuming that if your practices already work with pharmaceutical reps, they've got the information and they don't need us to make those connections.
I will say, this is Bobby again, that I work with a few different practices. Some work closely with the reps and some don't, but even the ones who do, the providers, the primary care providers often aren't necessarily aware of the resources kind of regardless, and then they end up kind of sending somebody to me, or the patient might not be aware of it. So I still do think that there is, even for the ones who are working close with the reps, a lot of room for us to provide that information, and in like you said, an agnostic format. So just some more feedback there.
And then, Kristen, if you're able to unmute, I'm curious to hear about your collaboration. If you're not, that's okay.
Hi, can you hear me? Okay, yeah, so we have a local pharmacy company called Brown's Pharmacy, and they recently they're under new management, and they're expanding their services. So now they have trained pharmacists who do diabetes self-management education. And one of our primary care practices who is participating in this program actually got us all together. And we've had a couple talks so far, and they are very interested in partnering with us and our PCPs to provide another level of support and education to the patients under this program. Their pharmacists are actually going to your trainings right now and listening into the same PCP educations because they want to learn what the PCPs are being taught. So right now we're just really trying to figure out how to make it work financially, because obviously their time is valuable and they can't do it for free. So eventually I think I'm going to need to reach out to you guys and probably set up a meeting between us all just to kind of talk through some of the details. But I'm glad to hear that others are kind of talking about it too. But I just thought it was really cool. And they came to us and they were very excited, and they had a business plan and a proposal already put together. And they just want to help the PCPs be successful and help the patients be successful, more or less. But yeah, so we're just kind of in the beginning stages, kind of talking through how that might look next year.
That's really wonderful. Yay to community pharmacies.
Yeah.
And I think one of the themes we've been talking about as a collaborative is how it's just scale-wise not going to be feasible for some of our practices or even POs to provide all of these services on site. Thinking about lower carbohydrate diets and training dietitians, similarly to what you're thinking about for pharmacists, are there ways to find scalable opportunities that anyone in the state can access? If there's anyone who's working on a similar program, we'd love to hear about it in the chat or unmute yourself. Lots of examples of partnerships. Meyer Pharmacy in different states. There's a collaborative in Minnesota that I'm aware of that's using those drugstore, grocery store based pharmacists to do adjustment of hypertension meds. So that model's out there, but this may be a new application of it. Anyone else who's working on similar things? That's really incredible.
I do wonder if are there kind of options for providers who, are involved in this collaborative, who want to start some of this with the patient, and then is there a evidence-based kind of stepwise option when they're met with barriers that we can do in the interim?
Can you give me an example?
Yeah, for example, if you want to start a patient on one of these medications and it's not covered for them, what is the provider's best next option? You kind of throw in it's kind of, well, I don't know what to do now. Do we have any logarithms or algorithms that a provider can kind of turn to in those moments while we try and figure out some of this other stuff?
Yeah, I think the right word actually is logarithm, because it gets so complicated that it is more a logarithm than an algorithm. That's a great suggestion, and I will take it back to Jake and our pharmacist, Heidi. If anyone has any tools, please send them to us, but really more of an affordability algorithm. Patient doesn't have an affordable SGLT. What's your next step? Patient's having trouble with insulin, going even all the way to, Walmart Rely On brand insulin's available for 25 bucks a month. That still, I find, not all clinicians are aware of that option. That's life-saving for some patients. So we will put our thinking hats on, because I think that's a good option, just to checklist or make an easy cheat sheet for clinicians when they just need to do something for their patient right now. The other thing we've been sharing in the trainings is just that it's not a failure if a patient ends up on a sulfonylurea or on insulin instead of a GLP or SGLT. We're doing the best that we can for these patients, and there are barriers that are, I think in this way that we're ahead of our time, or hopefully really moving to a new standard of care. Some of the things that we're finding out, I think, will push changes so that it's not that hard in the next 3 to 5 years. Any other suggestions? Jackie, Jake, anyone else?
Nope, I think that sounds good.
That covers it.
I'm going to show you our last slide and our save the date for our PO workgroup meetings.
There's one more explanation in the chat I just wanted to call to about a pilot. So Ashley was saying that St. Mary's PHO is partnered with BCBSM on an innovation for remote patient monitoring. They're targeting diabetic patients with an A1C of 9 or higher and providing them with education and training through their diabetic education center, RPM devices, et cetera. It's in the beginning stages, and they're going to include some patients that are a part of MCT2D as well. And so it'll be nice to kind of see that cross comparison. So I just wanted to share that. Make sure you saw it, Dr. Ashman.
Thank you. That's wonderful. And, Jackie, in terms of highlighting some of the innovations that POs and practices are bringing to us, what's your thought about how we'll be sharing those in future meetings?
I will take some notes on what we learned in this one and from our others, and make sure everyone's comfortable sharing it at this level, and we can kind of talk about a way to do that. Sounds good.
Yeah, I think part of our goal is to share best practices and things you've learned to bring everyone up to speed. Really lovely intervention, thinking about using some of the new billing and coding tools that we have for remote monitoring to make sure that we're paid and incentivized.
Okay.
Any other thoughts, concerns, brainstorms you want to add? Please share them. Otherwise, Jackie, I'll let you finish our meeting up.
Sure. So just that. Oh, go ahead.
Sorry, I have a quick question / thought, and this may not be the forum for it. So if it should go somewhere else, let me know. But as a clinical champion for RPO and trying to work with dietitians and other groups, I have felt like I've had a bit of a hard time with the dietitians and the low carbohydrate diet. And I was just wondering if anybody else has kind of had any pushback on that. I'm trying to provide them with some additional information that you all have provided for us as well. But just right off the bat, it felt like I was getting pushback on not meeting kind of traditional macronutrient, recommendations. And I just wondered if anybody else that came across that, or where else I should ask this question.
I see one yes in the comment. Looking at current ADA guidelines for nutrition, medical therapy, carb counts are individualized. And so it's this, I think, barrier moment in nutrition and dietitian training where, yes, I know that's what the ADA says, but years and years of the way we've been doing things can be difficult to overcome. So any other suggestions from folks on the call or from Jackie or Jake from the low carb training that might be helpful?
Well, I just did want to let everyone know that we are trying to work with ACDES, which is the Association of Diabetes Care and Education Specialists. We're actually attending one of their upcoming Michigan board meetings, and we already kind of introduced low carb diet to them, and we're talking about how we're using it in this collaborative, how it's meant to be able to be used with a vegetarian diet if that's what people are on, et cetera, like not being super prescriptive about it. We met with their main lead, and now we're going to be at that next meeting. And what we're kind of trying to do is exactly to your point, trying to kind of talk about how low carb diet can be used with patients and for type 2 diabetes and the benefits of it, and really just trying to get more buy-in from that group, and then hopefully be able to offer some education on low carb diet or kind of present our case for why we think it works well for type 2 diabetes patients, and hopefully get to the point where we kind of have maybe built out a list of dietitians that are low carb diet friendly or who would be open to kind of considering this for patients, because we understand that that's definitely a struggle, and we're trying to make the right connections to get our foot in the door to change minds on that.
Jake, our one pager on low carb diets, do you think that focuses on like a dietitian as an audience, or do we need to create any new materials focused on dietitians?
I do think it's a good start. Jackie, I know that you had sent that out quite a while ago. Maybe we can send that out again. But I think it's a good start, and maybe if you guys have suggestions after using it as to whether or not it's effective or if we need to develop something else, we would love to get your input on that.
I love these suggestions. Branding is so important. Let's find a name for it that is palatable and works for everyone, and also, avoiding negative connotations. So many people have a negative connotation towards keto diet, specifically in diabetes. In carbohydrate individualization. And then one more question about uploading CGM data. Jackie or Jake, can you take that one?
Jake, do you mind answering that? Will we be receiving information on uploading? Thank you.
So yeah, actually we are working currently on developing an entirely devoted web page on our website for everything CGM related resources. So this will include both provider-facing materials and patient-facing materials. They are going to be primarily focused on the two main CGM manufacturers, Dexcom and Abbott, that are most commonly used for folks with type 2 diabetes. And I am also here whenever and happy to have one-on-one meetings if those resources are not effective enough. It's a little bit different between device manufacturing companies and pharmaceutical companies. At least my experience has been that the trainings and one-on-one sessions that Dexcom and Abbott provide as well are quite useful and quite good. But again, if you're not comfortable utilizing their resources, I am happy to meet with you at any point. But like say, we will be sending out an informational email with a link to our new updated website page that will contain all available resources that you could possibly want in regards to both using a CGM and using the online platforms, the Clarity, the LibreView, how to download reports and upload them into your respective EMRs, and items like that.
I have a comment on that as well, just as something that we might find useful. For me, I use those web pages and those tools regularly, but the part I'm struggling with is how to implement it into the day-to-day in the office for the offices that I'm not at to do it myself. I've had a little bit of a hard time convincing the office manager that this is something that multiple people may need to be able to do, and how to incorporate that into the already very tight schedule of the PCPs and the MAs. And I'm not sure if there's any guidance out there on ways that have worked well in other offices that might be beneficial as well.
Yeah, so the traditional workflows I'm sure most people are aware of is that after you have clinical accounts set up on both Clarity and LibreView or whatever system it is that you're using, that the patient either is sharing the data with the clinic remotely through the different data sharing options, or upon arrival at the clinic, an MA takes their standalone receiver and uploads it to the online system. Either way, the MA, the medical assistant, is typically the one that downloads the data, meaning the PDF report from the online platform, and then uploads it into the medical record. In Epic, it would be like under the media manager and whatnot, so that when the patient is roomed and the provider is seeing that patient, they're able to pull that up in real time and review the results of the patient. The actual work of downloading a PDF from the system, if the system is already open, takes approximately 30 seconds, and then uploading it to the EMR obviously depends on the EMR, but shouldn't take more than a couple of minutes. Obviously, adding 2 minutes to every single patient does amount to a large burden, but that is the typical workflow. And we also hope to connect practices that have good workflows, a part of this collaborative, to other practices that are starting that process, to share best practices, tips and tricks, and things like that. And again, happy to have calls and discuss different options that we can personalize to each individual practice, because there is not going to be a one-size-fits-all solution. We are definitely aware of that. It's going to be a customized what works best with the way that you guys currently function.
And Ashley had shared in the chat that from St. Mary's discovery thus far with their innovation project is that the API are working with MyHint to deliver it via CCDA feed in the EMR is the best way to get CGM data. So kind of taking out that work of the MA needing to upload it. They've tested using MyHint and sending to Allscripts EMR and are able to receive that in the test phase. So now they need to figure out how Clarity and MyHint can collaborate and work together for data sharing.
Yeah, that's taking it to a whole nother level. Yeah. It's great if you guys can get it to work. We'd love to learn about your experience.
Any other questions before we wrap up? Well, thank you everyone so much for joining us today. We hope this was helpful for you, and we want to make sure that these meetings are useful for you and you're getting things out of them that you need. So we'll continue to kind of check in with you on making sure that we're covering topics that are important to you. We might solicit future topics for meetings from you so that we make sure we're covering things that are helpful to you and your participation in MCT2D. And thank you again for joining. Dr. Ashman, do you have anything you want to add?
Just an answer that yes, the 24th is a repeat of this meeting.
Yeah, we wanted to give everyone 2 options to join just because we didn't, with so many participants across so many different organizations, if we ran into like a recurring meeting that you had all the time, we didn't want to have a situation where one PO was never able to attend these. So we decided to just host these twice a month to make sure that we could accommodate everyone the best we could. So hopefully, if someone has a Monday 11 a.m. meeting every week, they can still attend the one on Wednesdays. So that was kind of our thought behind that.
Yeah, thank you so much for sharing. I think your input is so valuable, and some bright spots of folks who are doing really amazing things that we hope to capitalize on. And we will see you all next month.
Yeah, thank you so much, everyone. We really appreciate it.
Dr. Ashman, I'm going to end the meeting.
Goodbye. Thanks.